Let's run a scenario. You're dispatched to a private residence at about 10:30 a.m. for a 56-year-old male complaining of new, mild, low back pain. On arrival, he's sitting on the couch, alert and oriented, no obvious distress. He says, it's nothing too bad, just some soreness in my lower back since yesterday. But my wife insisted I call since it feels different from my usual backaches. You know how wives can be. One of the things I hate about social media is it relates to medicine, especially pre-hospital medicine, is getting a scenario or an interesting x-ray or an interesting EKG and never getting the answer, or having to wait a week for the answer or anything like that. And then I just scan through the comments and they're all wrong and they're all silly and they're all not helpful to me. I want to know what the answer is for the person that put it out and thought it was important. So that's what we're trying to do here. I'm going to run through a scenario. You're going to think about a couple of things. You're going to think about what you think could be going on, list of other potential things that can be going on, your treatment priorities, and then we'll discuss the whole mess. If you like this kind of thing, this is Prehospital Wisdom. Make sure and hit the like and subscribe button down below. So, in any case, you get dispatched as mild low back pain on a 56-year-old male, right? The initial information: history of present illness. The pain began yesterday afternoon while doing yard work. He describes it as dull and achy in the right lower back. It's kind of non-radiating. The intensity is 3 out of 10. So it's kind of along the SI joint and along the top of the pelvis there. The intensity he puts is 3 out of 10, states it's worse with movement and improved with rest. He denies any specific injury or heavy lifting. Took some ibuprofen last night. It helped a little. He's got a history of hypertension and hyperlipidemia. He smokes 1 pack a day, 35 pack year history, no known history of specific back injuries or bulge discs or anything like that. He takes lisinopril, torvastatin, and 81 milligrams of aspirin a day with no known drug allergies. Right now, he's got a heart rate of 98, blood pressure 168 over 92, respiratory rate of 18. He's sat at 97% on room air. And if you were the kind of system that likes to check such things, he's not febrile. So for his general appearance, he is well developed, a little bit of a beer belly even. Mildly uncomfortable. He keeps shifting position like he can't find a comfortable spot, but no real acute distress. He's kind of shifting between weight on the left cheek, weight on the right cheek, leaning forward, sitting back. He's kind of having a hard time finding that comfortable spot. Just based on that, I know there's not a whole lot getting into it, but I need you to think right now kind of the way a paramedic thinks. So the way that I teach people to work through this is to start thinking of some major problems that this could be. What are the most common problems that this could be, and what are the most life-threatening problems that this could be? Stuff that we need to rule in or rule out really quickly. Based on that, there's going to be certain specific findings going on that'll let me test certain differentials, right? So what I want you to do is pause the video. Yeah, I know no one actually pauses the video. I get it. But I would like you to make a quick list of like 4 or 5 differentials, some of the things that you would check to rule that in or rule that out, that kind of thing. We're going to come back in 3, 2, 1. We're back. So a good list of differential diagnoses here. The first obvious one is musculoskeletal strain. Fits because the onset's during yard work. It's localized dull ache. It's better with rest and NSAIDs. It's not quite fitting based on there's no specific lifting or twisting injury. His age is greater than 55. There's a higher risk for other problems. Someone at that age group is at higher risk for other issues that I kind of need to at least consider. And landing too quickly on musculoskeletal strain is going to cause some problems. So to rule it in or rule it out, I'd palpate for tenderness, especially in the paraspinal spaces, ask about recent exertion, test the range of motion. Pains that worsens with paraspinal palpation or specific movements supports musculoskeletal cause. Another one is a kidney infection. It's also called pyelonephritis or kidney stone. So renal colic fits because of locations in the flank or the lower back. Why to doubt it? The pain's not colicky, it's not severe, there's no dysurinary or urinary frequency reported yet. So I want to ask about urinary symptoms, hematuria, nausea, vomiting, check the costovertebral angle tenderness with percussion. Number 3, abdominal aortic aneurysm, expanding or leaking. Why it fits: the age is greater than 55, he's a male, he's hypertensive, he's a smoker, back pain may be vague and mild initially. Elevated blood pressure may be compensatory, but pain is pretty mild. It's not abdominal. You haven't checked any kind of pulsations yet, and his vitals are stable. So I need to palpate the abdomen gently for a pulsatile mass, ask about abdominal or groin pain, monitor for sudden worsening hypotension or syncope. Spinal infection like an epidural abscess or discitis. Why it fits, because of atraumatic pain different than usual. Why to doubt? No IV drug use, no recent surgery, pain's not severe progressive, no neurodeficits. Rule in or rule out, ask specifically about IV drug abuse, recent infections, immunosuppression. We can perform a neuro exam, strain sensation reflexes, sphincter tone if indicated. Don't test sphincter tone in the pre-hospital setting, please. Thank you very much. Another one could be metastatic cancer of the spine. It's new, unexplained atraumatic pain in an older smoker. So why to doubt it? The pain's not constant. There's no night sweats, no weight loss or fatigue reported. We could ask about constitutional symptoms like those night sweats and fatigue and whatnot. Pain worse at night or unrelieved by rest raises suspicions. So based on that, our key questions or exam, we need to figure out, is the onset gradual or sudden? Is there anything that makes it feel better or worse? Other symptoms like dysuria, hematuria, fever, weight loss, abdominal pain, groin pain, stuff like that. Does he have a history of cancer, IV drug abuse, or surgery? I need to do a better secondary exam. I need to localize for paraspinal tenderness and deep. I need to check for abdominal findings like abdominal masses or pulses. Neuro exam is always good when we're dealing with back stuff, especially lower stuff, push-pull with the ankles, so that's dorsiflexion. We can percuss the costovertebral angle region for kidney involvement. So as the paramedic continues questioning, the patient reports occasional abdominal fullness recently. On exam, a pulsatile abdominal mass is palpated. It's mildly tender. The back pain is not worsened by the palpation of the paraspinal muscles. No urinary symptoms, no neurodeficits. Treatment priorities for this kind of patient, even without knowing what's going on. So keep in mind, in EMS, you're not going to have the answer. You're not going to know what's going on specifically. And so we need to be able to make our treatment priorities without knowing specifically what's going on. Sometimes we have a really good idea what's going on, but that's not always true. What do you want to do as a paramedic? Number one, you want to recognize the threat early. Back pain isn't always benign. Risk factors and abdominal mass equals AAA until proven otherwise. Now, fortunately, back pain is one of those complaints that paramedics, I'm not going to say they minimize it, but when there's a patient and 2 paramedics on the bus, that means there's probably 3 people with back pain on the bus, right? This is a really common thing that doesn't actually generate all that much sympathy. My job and your job is to make sure that you're not missing something bigger. It's one of those most important questions. What else can be going on? Because we don't want to hurt our patient, we don't want to miss something, but also secretly, we don't want to look stupid. Number 2, avoid unnecessary movement or exertion. Keep the patient calm, minimal handling. No matter what the problem is, that's going to help. Number 3, we're going to establish IV access, but avoid excessive fluid unless the patient's status changes, right? Permissive hypotension is the goal. This patient doesn't need a whole lot of fluids and stuff like that. Maybe some pain meds if he wants it at 3 out of 10, some Toradol or something like that might make him feel better. Number 4, we're going to transport him to a facility with vascular surgery capabilities. If I'm thinking it's a AAA, otherwise a normal hospital. Final diagnosis in this case is expanding abdominal aortic aneurysm, or AAA. An abdominal aortic aneurysm is a focal dilation of the abdominal aorta, often caused by atherosclerotic degeneration of the vessel wall. Risk factors include age, male, sex, smoking, hypertension, hyperlipidemia. As the aneurysm expands, it can erode into surrounding tissues, producing vague back or abdominal pain. Small leaks or rapid expansion can cause irritation before catastrophic rupture. While the chief complaint appears to be minor, it's mild low back pain, the underlying pathology is life-threatening. Missing the diagnosis could lead to rupture or death. So hopefully you got it. This is Angry Bill for Prehospital Wisdom. Until next time, what else could it be? Stay safe. See ya.